Welcome back and thanks for staying with us. This is Daybreak. In the studio with me, Brown Ashira Olale, also in the company of Dr. Brian Lishenga and Dr. Dennis Miskela. Earlier on, we had Dr. James Nyikal, who joined us from Kisumu County on a mission to fact-find some of the problems that have been listed by the Ministry of Health as the non-existent healthcare facilities across the country that have been flagged. Gentlemen, thanks for your time. Dr. Lishenga, coming to you. What was pointed out by Dr. James Nyikal is a reality that can't be washed away, is it, or ignored by the fact that there was an inability to detect this fraud. But the question is then, what's the point in procuring such an expensive system that was unable to?
Yeah, this is what I would call theatrics. You know, there's a lot of theatrics around this fraud detection. If you look at the Cabinet Secretary's ex-Twitter handle, he has posted many pictures there, Honorable Duale, that fraudulent practices that have been flagged include upcoding, falsification of claims, conversion of outpatient into inpatient. Let me just tell the public here, what is upcoding that Cabinet Secretary is talking about is where you bill for a procedure that is more expensive than the one that you did. So, for example, you do a simple appendicectomy. You know, what
is that?
The removal of appendix. Okay. You know, when appendix is inflamed. SHA is, you know, is reimbursing, let's say, 60,000 for that. Okay. But in your notes, you write that you did a laparotomy, let's say, a more expensive procedure that you get 130,000. This is what he's saying is the fraud. Now, let us go to how the digital 104 billion system can detect such a fraud. This fraud can only be detected, for instance, by looking at the laboratory tests that were done, the imaging test results that were done, the surgeon's notes that were prepared for theater, you know, the discharge summary. Now, I will ask, when we look at the SHA portal, these documents are usually uploaded as physical copies. You scan and upload. You scan and upload. So Dr. Miskela's handwriting, and you know how doctors write. Yeah. You know, Miskela scribbles something there. He says, oh, we did this, upload. Somebody else discharge summary, you know, the lab results. Now, for AI, the AI that Honorable Duale keeps telling us, AI-powered system, fraud detection, 104 billion. The AI is supposed to be trained to read Miskela's handwriting so that it can read and see, okay, so Miskela actually, these notes he has written do not actually correspond to a laparotomy, they correspond to a simpler procedure. There is no such AI system. It has not been built. The whole thing they are talking about here, that they have a system, is actually falsification of records. How do you detect falsification of records without actually reading the actual records? I would challenge Dr. Nyikal to do something. I want Dr. Nyikal to go to Digital Health Agency and ask them to open the server. You know the way we do it during elections, we ask for the servers to be open. I challenge him to go to DHA and ask them to open the server and see, really, is there an AI system at DHA? Secondly, Abdi, the whole issue of the minister. Minister is everywhere. The minister is everywhere. And the minister is making statements that are supposed to be made by the board of SHA. He's making statements that are supposed to be made by Massimo Ngangi. Seriously, when will the cabinet secretary allow these competent professions to work? Today, I think literally, if he was, you know, for lack of a better word, the PS, my good friend Dr. Omo Luga, has been reduced to his PA. Massimo Ngangi accompanies him on every single press conference. SHA doesn't have directors. You know, we are now just recruiting. They shortlisted the other day directors. If you go to SHA, SHA is a ghost house. There are no people working in SHA. The only thing you see is Massimo Ngangi accompanying CS Duale everywhere. When does she get to sit down to work? The board at SHA, when does the audit committee of the board, Duale has given 1,000 facilities, 900 of them fake that closed 3 years ago. He's now making big pronunciations that he has fought fraud. 900 facilities are closed in 2022. Now,
Did we have this system in 2022?
No, there was no system. In fact, let me tell you, we have combed through that that Duale gave to DCI. Yeah. I pity DCI because I don't know what DCI will be looking for. Those facilities, many of them have not been in operation for 3 to 5 years. It is a waste of public resources. You cannot send people on a wild goose chase.
So that is 1,188.
998 of them.
Totally handed over.
Yes, yes. But 998 of them have not been in operation for the last 3 years, even before SHA came into being.
So how many facilities are in operation of the list?
In that list, only 85.
85.
Only 85. So what Honorable Duale is trying to tell us, that he has fought fraud so hard using a 104 billion system to look for 10.6 billion. And by the way, I should inform the country that today, as we are seated here, a lot of those claims that Duale had said they have rejected, they have now reversed. They have returned to facilities because they have discovered that they are going to face litigation. Okay. So they have returned. So it's not even that. So the minister should stop theatrics. The Ministry of Health cannot be run by drama. It cannot be run by, I hear he's now want to run to St. Mary's Mumias to go and check and see if he can open. It cannot be run like that. St. Mary's Mumias might have had its own problems, but it is a hospital that the community depended on that was brought on its knees by NHIF debt.
Okay.
When is the minister paying NHIF arrears?
So this is the point, Dr. Before I move to Dr. Miskela. Of the facilities, 85 you talked about, how many fraud what is the number that, as the association, you have managed to detect as well in appreciation of the problem?
We have done whistleblowing. Yeah. As RUFA, we have whistleblown. We know some facilities that are ghost. In fact, Ayub, this whole story of ghost facilities, we are the ones who whistleblew on ghost facilities. If you go to the RUFA X account on Twitter, you will find that we actually sent people somewhere in Nyamira and Kisii at night to check a facility which had been paid 10 million shillings. That facility was not even open that night. There were not even lights, not even a watchman, not even a squirrel could be found. That facility had received 10 million. We are the one who whistleblew on this. What they are doing is running around because the reality, Ayub, is that this ministry has no idea where the fraud is. They have been paying fictitious claims to fake hospitals. Okay. Now, you must ask ourselves, if there are fake hospitals in Kenya, who registered fake hospitals?
So there's an entire agency that is responsible.
The same KMPDC, under the cabinet secretary, registered the fake hospitals. Now, who contracted the fake hospitals? It is the same SHA under the minister that contracted the fake hospitals. Who paid the fake hospitals? It is the same digital health agency with the 104 billion system that paid the fake hospitals. Who came to announce that they have paid fake hospitals? The same cabinet secretary came to announce that they paid fake hospitals. They must stop taking Kenyans for a ride.
Okay. Dr. Miskela, the Kenya medical practitioners, the KMPDC cannot, is it also, run away from this problem? Because ideally then how would a facility that is non-existent make a claim without proper inspection and without their extra eye?
So, thank you. First of all, I want to respond to something that Dr. Lishenga said. I really want to cut CS Duale slack on certain things. First of all, when this SHA Act was being formed, Waziri was not there, one. Two, for a fact is that the SHA debate has been over-politicized. And for the longest time, we have not had a political counter-narrative on some of these issues. And sometimes I understand why he has to come out of his way to speak up. And Duale never shies away from saying that he's a politician. Yeah, these are the people in the board and in the management of SHA may not have the temerity to argue back and answer the political statements being made. But also said is that in the NHIF we hear about fraud, but we could not pinpoint any specific hospital at the amount. Give credit that at least in this 104 billion with all these failures, we are able to point that there are certain facilities, we can point names and the figures around the fraud. So I would give it to that. My biggest challenge with this system is the whole idea that somebody somewhere sold us a snake oil. Yeah. That this 104 billion system was going to cure everything. Yeah? We were told that SHA was going to cure all the maladies of NHIF. NHIF only needed 700 million to fix their system to detect and prevent fraud. 104 billion later, we have a system that is just detecting but not protecting the fraud. So that's the question that we should ask ourselves, that were we conned on the system?
Snake oil.
Is it too late to tell them that they didn't honor the end of the bargain? Because if you promise me that you are going to take me to Kisumu in a matatu, then I find myself in Meru, it's not just enough to tell me that the bus has stopped, get off. You have to take me back where you found me and take me to Kisumu, because that's what you promised from the word go. And that's something that this whole system must give to us. Secondly, there's another problem that has also come out of this SHA story, that in quest to have people register for SHA, there are certain political statements that have been made by the pro-SHA team that don't make sense in the insurance world. There is no way anywhere in this world where you can tell somebody that they sit back and tell you how much they can contribute to SHA. Kenyans, we have to agree that Kenyans are one of the most honest of people. The mean testing, people are lying about it and the amount they're supposed to pay. We told them, that guys, can you agree on a minimum that at least you tell someone that you either pay 500 shillings or they take this route. Yeah. That will be assure them of a certain amount of money. One. Two, telling people that just register, just register and you'll access primary health care and the emergency fund. Then people just register, 25 million people have registered, but only 3.8 million are paying, and most of them are the people in employment who are only who are paying. So these 3.8 million people are carrying the burden of everybody else. But even beyond the carrying the burden of contribution, we have a fourth fund made for the public officers, my members, civil servants, who contribute almost 5,000 every month above and beyond the share contribution of the 2.75%. Like for me, if you deduct my 2.75% of my gross salary, I'll give a certain amount. You add plus the medical allowance, I give like 13,000, 14,000 per month. But that fund that is exchequer deducted and is assured as a contribution has not been paying hospitals. So you go to most hospitals, they have rejected that comprehensive cover for civil servants. Okay. So there are certain questions that must be answered. But more importantly, as I wrap up that bit around the healthcare financing.
No, we'll come to the financing. Let me seek some clarity from Brown as well.
Yes.
So what then happens if the only 3 million plus shoulder? This is already a marginalized lot, is it? Who are
in the civil service?
Yeah, whose pay slips are squeezed.
Correct.
And the effect again on the household is further consequential. Ideally, then, how is it supposed to be working? Because the messaging was that then, if you register, you will access primary health care at no cost. So what then happens?
It is an unfortunate thing. I think one of the reports that were released in 2018. Back then, it was out of pocket. You know, the reason why insurance is there is it's supposed to cushion. A normal person from actually overspending, catastrophic spending. That report is that I think the spending, out-of-pocket spending, actually went high. And I really plead and really sympathize with the civil servants, where we sit, and Ms. Keller can be able to bear with us witness. We don't have an option. Because when somebody has your pay slip, he goes in and maybe gets the money and, pays that amount of money. But given an opportunity, even as civil servants, even if we were to ask, they should stop. I think we'll be the first people to say, we do not want to subscribe. Because even if you look at even where that money actually is going, I began by saying, we have members who are actually stuck in the hospitals without really, SHA has actually completely negated. Let me tell you, it's very painful. When you go to a hospital, you want to seek a health service, and you can't be able to access it because the SHA has not actually paid for what is supposed to be paid for. So it's a problem when it's actually not working. I think the government has to swallow the bitter pill. It is good to be very honest in this discussion that this thing really is not really working. Can we be able to look at the structure? Let's look at the systems. If the 104 billion, whatever, is not working, I think we also need to demand for accountability. We need to bring in, even to loop in the Auditor General. I think it's high time we need to ask for accountability in terms of, because we also need to know where our taxes are actually going, what is happening with this money, because it's also not possible to pay a ghost facility, because how do you pay a ghost facility? Somebody has to take responsibility. If you are paying a ghost facility that never existed, really, somebody has to take responsibility, and it's not actually very fair. It's actually being very, very unfortunate to Kenyans who are actually going out of their way to contribute to this SHA thing.
Yeah, actually, Dr. Nancy Gadongo, the Auditor General, Regarding 2023-24, highlights glaring inconsistencies in the procurement of healthcare information technology digitization system, which is running the Social Health Authority. And she pointed out unbudgeted procurement, no procurement plan, uncompetitive procurement, violation of Article 227 of the Constitution, undefined scope of work amount to 7 billion, trained, support customer education, number of healthcare workers never disclosed, management in breach of the law. This is already there, is it? And
exactly.
It's in the financial year 23.
Exactly. It was actually pointed out. And actually, the Auditor General did justice to us. The only problem we actually have with the Ministry of Health, that I want to agree with Dr. Lishenga and my other colleagues, is that we do not have listening leaders. If you have, when you ask like this, they say they label you, you're a critique of the system. Instead of listening to the respondents, or rather improving or taking advantage of the respondents actually coming from the ground, they will label you as a critique of the system, and therefore you don't want the system to work. The truth of the matter is, the reason why we transitioned from NHIF to SHA is that SHA and NHIF was mad with this fraud thing. The mismanagement and the fraud issues were actually on a top notch. And therefore we were expecting that with the inception of the SHA, things were actually going to work for Kenyans. And that's why you can be able to see there's a problem at the ministry. So we need to look at the report. And sometimes I also feel for the Auditor General, because sometimes it's also crucified for speaking the truth. Because sometimes when he brings up those figures, somebody says, you know what, we are going to deny you money. We can't give you money to run your office because actually what you're saying the truth. Okay. So it's good that the government swallows a bitter pill, that there's a challenges in regard to operation of the SHA. And then if it's about the SHA management, or rather if it's about the interference of the minister in the operations of the SHA, I think we need to stay clear. The SHA need to be independent.
Okay.
It need to be independent.
Yeah. And yesterday the president made some pronouncement. We'll be getting to that. But Dr.
There's something I'm forgetting, which I want not to forget. You know, sometimes also it's not very easy being a leader in Kenya, because we are a very, very political and very, very intellectual population. For example, when the president came and said that there were certain fraud cases that he needed to be audited, and he formed a team to audit it, it is us also very, very Kenyans who went and blocked that team from auditing. Yeah? Now, we have, again now, the same government is telling you that we have picked up certain irregularities that we'll have to investigate further. We are also refusing that. So we have to decide also as Kenyans that once you have accepted who we are, then you also have to give the institutions some independence. The KMPDC of this world should be let to do their thing. Yeah. In SHA itself, we have a dispute resolution tribunal that if they were allowed to do their work, we don't even have to go and tire the DCI people with wondering what appendicectomy is. Because in the SHA regulation itself, there is a mechanism, because they already foresaw that no matter how perfect a system is, you cannot cure a broken human spirit. So Kenyans, once we know that you can never cure all fraud. Fraud, insurance fraud, is a global problem. It's one of the biggest losses even in the Americas. Yeah. So this tribunal, if we let it also do its work properly, then I'm sure that we can also cure some of these things and save the country. This policy of is SHA working or not?
Okay, so this is what the president said, Dr. Lishenga, Dr. Miskela, and Brown. He spoke at State House in Nairobi and said the following.
And I'm going to have a meeting next week with our members of parliament, with governors. CC, I am going to pay for $1.5 million as national government. Mimi nataka governors walipie another maybe 1 million. Hao wabunge, you know, every MP hako na pesa anaweza kulipia wale watu maskini katika constituency yake. So that we can... Tunaelewana, my friends? We must be deliberate. Saa hizi, kuna hospitali tunawatumia pesa kwa kutreat wananchi wanashangaa. Because they have never seen. Yeah? Because they have never seen money being sent.
So, Dr. Lishenga, coming to you. Ideally, the people the president is talking about are Kenyans, and they were supposed to have... been catered for somewhat, either through the contributions they make or the means testing, which then establishes what they're supposed to be paying annually. That's the premium. So how comes, again, that the state has established there are people who are unable to pay for themselves? So we are talking about 2.5 million people, plus what the governors would pay for, as per the president.
I think that, as my colleagues have said, there is a problem with the design. Proxy means testing was a problem. You know, expecting. You see, who goes to your house? I mean, not even your house. They meet you at a primary school or at a local church or mosque, and they ask you, does your house have tiles? Do you have tapped water? How many children are in school? Do you have electricity? Do you, you know, how much rent do you pay? And then you expect Kenyans to say the absolute truth when they realize that, you know, they ask you, okay, do you have a means of transport? If you have a motorcycle, you know, once you have a motorcycle, your premium goes up to 1,500. As soon as one Kenyan got that premium and they told their neighbor, all the neighbors who had motorcycles refused to say they have motorcycles. Yes. Okay, so everybody just abandoned the whole thing. And we told these guys from day one that this thing you are calling proxy means testing is going to fail. It cannot work. Now, you know, we have a very bad culture in this country. I admit NHIF had problems. What made NHIF unpopular, for instance, was many patients who went to hospitals and NHIF refused to approve their claim. You know, somebody say, I have paid money for 5 years, I needed surgery, they refused. Do you know how SHA cured that problem? SHA cured that problem by approving all requests. You know, so the focus on politics in this country, in the Ministry of Health, is ridiculous. How do you approve each and every request? They approved hundreds of millions of requests. You know why? Because they wanted the soundbite from Mwananchi that SHA is working. Today, if you go online, Mwananchi tell you SHA is working. Do you know the definition of SHA is working by Mwananchi? Is that I went to hospital
and payment.
And no, not payment was done. I went in and walked out. And then how Mwananchi says it, nililipiwa na SHA. But they forget that when you walked in, it's like you went to a restaurant. I went with Miss Keller or Brown to a restaurant, or Miss Keller and I and Brown. And then we say, Brown said, you guys, I will pay for you. Then you walk away. And then the restaurant, then Brown takes the back door and does not pay the restaurant. But me and Miss Keller have eaten and gone away.
But ideally, that serves the purpose on the part of the patient.
Of course, it serves the purpose on the part of the patient and of the politicians. Because the politicians can now say, look, Kenyans are saying SHA is working because we approved all the claims. The danger that has happened is that the millions of claims that have been approved, the hospitals trusted SHA. We trusted SHA. We trusted SHA. We trusted the president. The president said they will pay. So when a SHA patient came to the hospital, we never asked them. We said we trust the president. We trust the ministry. We gave the care. Now, imekuja wakati wa kulipa deni, all those denis are fraudulent, number one. So
but are all,
people
okay.
No.
Dr. Lishenga,
people have to be very careful. We have to be very careful with what we are talking about.
Let's be methodical as well.
I want to get to the point here.
How many claims, for instance, from just an estimate from the private association you represent, were all claims that you guys have made have been rejected?
The proportion of claims, let's start with what has been paid.
Yeah.
What has been paid, out of what we have submitted, what has been paid is...
You submitted how much?
We submitted by mid of this month 94 billion.
Okay.
94. What has been paid is 53 billion. It's on record. So we are saying about 53% has been paid, 47% is pending. Now, out of the 47% that is pending, the ministry is telling us 25% of it is fraud. You get what I'm saying?
That is of 41 billion. Yes.
They are saying. But, and then we say it, healthcare provider, and by the way, it is not private hospitals. You know, people are confusing because of the sound bites that are coming out of here that it is private hospitals. No. When we say 10.6 billion, it is not money for private hospitals or faith-based hospitals. It is all hospitals.
All the hospitals.
So what the ministry is saying is that a quarter of the pending claims are fraud. Now, this quarter, I posit it to the Kenyan people. The reality of the matter, if you ask Aden Duale, you ask Lenayara, these people of DHA and all this, they don't know. They don't know whether it is fraud or not. They don't know what has touched. And that is why we are here discussing the 104 billion system. The 104 billion system must supposed to enable them to know. But they don't know. So what they are doing, they're shooting arrows in the dark. Shooting arrows. They are hoping it will catch something. Now, let me come to the issue of what the president is saying about 1.5 million Kenyans are going to pay it for. Number one, under NHIF, I was saying we have said everything was bad. Not everything was bad. Under NHIF, there were at least 2 million Kenyans who were being paid for under the indigent scheme. These were being paid for by the government. And you could go to hospital, the elderly, the orphans, and vulnerable, and you receive care because the government has paid. So today, when His Excellency the President says he has now identified 1.5 million, and people are thinking, wow, now SHA is doing magical. No, this has been there. Under NHIF, 2 million poor Kenyans who are being paid for by the government for their care. But what is even more concerning, how will they determine what premium to pay for these 1.5 million people? Are they going to subject all of them to proxy means testing? I don't know. You know, they will have to come up with a number which will return us to what Brown and Miskela are saying. Flat rate. Give a flat rate and pay for people who cannot do it, and allow Kenyans to pay a flat rate. You cannot go around. I must compliment some counties, by the way. For instance, Murang'a County has paid for its indigents for the last 1 year. We know this. They have been paying for their indigents. Many other counties have not gone as far as to pay for their indigents. It is not enough for the president to declare 1.5 million Kenyans. We must challenge county governments to put money in place. But even more important, you cannot tell Kenyans, and my colleagues have made this point, enda register, uende tu hospitali, malipo itakuwa bure. Hakuna mali?
Yeah, and Brown is coming to you on that point. The president pointed out that...
It's very dangerous. It's very dangerous. Let me say why it's dangerous. 90% of the reasons why people go to hospital are for outpatient reasons. 90%. 90%. Very few. Only 1 out of 10 people, on average, go for inpatient care. 9 out of 10 people just go for outpatient. Now, let me ask you, Ayub. If 9 out of 10 reasons for why you go to a hospital are free, why would you contribute?
Okay.
This is the problem.
Yeah, Brown, then what is the interpretation of that message by the president, that it's shocking that hospitals are getting money? That's what he said.
But which is not true. I can agree with Dr. here that, hospitals, I was privileged to interact with some governors, deputy governors from Meru and maybe Murang'a and other places. And we really agreed that past 3 months, they have not actually managed to pay, to be paid by SHA. The other day, General Hospital of Kakamega actually gave a circular to some of its employees saying that we cannot be able to afford to pay your salary because SHA has actually not paid us. And therefore, you're actually going to get a half of your pay. That's a very dangerous thing. And remember, these are the people we're actually depending on to actually offer service to these Kenyans. If you say, for example, this money has been paid for, then we have millions of Kenyans flocking in the hospitals. Where do you expect, and that's what Dr. Lishenga said, that's why we are actually accumulating a lot of claims and we are actually unable to pay. The truth of the matter is that we need to go back to the roots. We need to go back to where the problem is and address that problem. I began by saying universal health coverage is in danger. Is actually in danger because we cannot be able to have UHC program succeed without financing. We have problems in terms of HRH and I think human resources for health, and we are lagging behind what's actually expected by the World Health Organization. And we cannot be able to achieve a universal health coverage for each and every person if we have those challenges in terms of financing and human resources for health. And maybe I want to also to bring in another angle that SHA has also brought in. I represent a constituent of public health officers. We do preventive medicine. It is important, and I think the president needs to understand this. And I think when he was coming to the office, I think he had an idea of what prevention is all about. And it is important that SHA also purchases preventive healthcare services in this country. We have been conditioned as a nation to think that we need to be falling sick. Okay. We need also to demystify the myth that also Kenyans can also be very healthy if we be able to maintain this, be able to maintain the social determinants. Because for even for someone to be healthy, there are other social determinants of health. So we need to also make sure that we also try to finance the health system, systems. Also, we should also have a discussion on how we can be able to also to have attitude change, behavioral change on how Kenyans need to live healthy. We need to tell them that, for example, smoking can also lead to lung cancer, malaria and all those things. So the disease burden need to go down because in as much as our facilities are also overburdened, let me tell you, we might not be able to reach those highest attainable standards of health that we actually intend to. But if we can be able to empower the preventive arm, the curative arm, and all of them need to have commensurate funding, that's the time that we can be able to realize the universal health coverage and health for all will be realized.
Yeah, and a couple of feedback, especially for you, Dr. Brian Lishenga, from will be responding to these questions, and of course talk about the fate of universal healthcare workers. Yesterday, there was a somewhat breakthrough between the Council of Governors and the Ministry of Health regarding their fate, and it appears to be now a swinging pendulum between COG and MOH. Yes, Dr. Miskele.
I need to comment on something the President said.
Yes.
You know, the positive out of the old statement, because these are new things, it was in SHA, in NHIF, but with SHA it has been delayed, that in any insurance, the principle of pooling of risks reigns supreme, whereby those who are contributing must be more than those who are claiming it. You get that? So this component of 1.5 million people coming on board is going to put a very, very big, shot in the arm, going to help in the fund. My problem with some of these solutions.
How much did we have on the NHIF, Dr. Lishenga?
We had 2 million Kenyans.
2 million. Contributors. Yes. No, I'm talking about the contributors.
But the contributors were about 7 to 8 million. Yeah, fluctuating.
Under this current scheme?
I mean, we have the numbers.
We have 3.8 million people contribute out of the 25 million registered. Yeah?
I think maybe.
So do we pay?
Just in fairness, I think the number has risen slightly. We have about 4.4 million, of which 900,000 are in formal sector and 3.5 million are formal sector.
Okay.
Public sector.
This is the problem.
Let him just reach the point. And
let me just clarify this. The challenge with some of these solutions that we are solving these problems in silos, that today you solve this and ignore the rest. Let me tell you, even if governors are to contribute for the indigents, we have to ask ourselves that what are the drivers in cost of care in this country? Yeah, I don't think that the drivers in cost of care, some of the things that we're talking about. What would make me, a retired primary school teacher, have to look for a private hospital? What would make me leave a public hospital? It's because somebody told me that once I register and pay, when I just walk in and out, I'll be treated. But then you go to these hospitals in the counties, there are no healthcare workers. There's no drug. Unaambiwa go do X-ray nje, end ufanye ultrasound nje, end onwe dawa nje. So this thing of sending patients out there also discourages people from contributing. But more important, that in the heat of the politics and wishing Kenyans and the soundbite that he talks about, we might have taken some of these things out of context. There's nothing like free healthcare in this country.
There's nothing.
Somebody must pay for it. In our country, the first person who pays for our healthcare is through taxes, the money allocated to counties and MOH. Secondly, we have the donor programs. Then you have 3% of Kenyans having some private insurance in this country. When you combine all this, we have a shortage of almost 35 billion in the financing of healthcare system. That 35 billion, somebody must pay for it. And Kenyans who are not told the truth, that SHA was only to stop catastrophic spending. It was not supposed to stop spending. So it was supposed to stop you from selling your land or stop you from dying because you can't afford. But they still must be told the truth, that there's some top-up, that is called the co-payment, that nobody told Kenyans about. Yes. So when you go and then you're told to co-pay, you feel robbed because you are promised something different. That's number one. Yes. Number two is that we have to tell Kenyans the truth that at certain point when you are contributing to this, we must introduce a level of waiting. I told the SHA team the other day that we must introduce a level of a waiting period. You might want to be popular, but sometimes popular is not very famous. When you go to the market, the guy is having monkeys, will have the biggest crowd. But when people go home, they go to the mama mboga. So yes, you can tell people that you can get it immediately. But I cannot just pay, then get cover. You must make Kenyans know that if I pay, I have to wait like for 3 months. What it makes people do, because you know when you fall sick, it makes you to contribute, knowing that the day you fall sick, you don't want to be caught off guard by the waiting period. You must introduce that carrot and stick to make SHA sustainable. Okay,
so let's sample the feedback. And this first one is from Nyeri Town lawmaker Duncan Mathenga, who as well is a member of the National Assembly's Health Committee.
Okay.
And he says, SHA and the Kenya Medical Practitioners and Dentists Council must be held to account. On this, we are on the same page. However, on NHIF deaths, is the person who went to court to oppose the verification a member of the private healthcare providers? You respond to that?
Yeah, I will. Do I go ahead?
Yes, first question, yeah, you respond. You'll respond to that question first.
Honorable Madenge is my friend.
Yeah.
And Honorable Madenge knows that he is just sending Kenyans on a wild goose chase. The person who went to court is a renowned surgeon, from the public sector. He works in the public health facility. Dr. Gikenyi works for the public health facilities. He's not working in private sector. So please, this is a propaganda that we must stop. As Dr. Nyikal said previously, there is no private healthcare system and public healthcare system. There is only one healthcare system for all Kenyans.
Okay, so the second one is still on the same, which continues from Duncan Madenge. Yeah, no problem. I can get it from the screen. Have the private healthcare providers sought to be enjoined in the case as interested parties to expedite the conclusion of the case?
Honorable Madenge, the case has been concluded. We do not need to be enjoined. The High Court in Eldoret said that the Cabinet Secretary had no power to form a verification committee for public money. And also the High Court said that you cannot have outsiders looking at confidential patient records. Therefore, any verification of NHIF debt that is required must be done by SHA. So this matter has been closed. What we expect to happen is that the debt, if there is any verification, should be done by inside SHA. By the way, Ayub, do you know by the time SHA came into force, 60% of the NHIF debt had been verified, closed, and done? There is no need for other verification. I think what needs to happen...
what was the amount of money to be paid?
30 billion shillings.
30 billion?
Yes. I think what needs to happen...
And was never paid?
It was never paid. Hospitals are closing because of NHIF. You know, SHA can be... we can sing till tomorrow about SHA. But unless we agree that the NHIF legitimate debt is debt belonging to SHA, hospitals will continue limping. But let me not talk about hospitals. Patients. Patients should not go to hospitals, as Ms. Keller has said, found no nurses, find no drugs, find no equipment. People must ask yourself, why is this hospital not having this? Hospitals require money. There is no free healthcare.
Okay. No free lunch.
Exactly.
No free lunch.
Yes. The final question still from Honorable Madenge, and this possibly coming your way. What's their position on the fraudulent claims originating mainly from the private sector providers in the spirit of self-regulation?
Honorable Madenge, I can tell you for sure that no publication from the ministry indicates that fraudulent claims come from one category. Do you know, I've talked about these sound bites, the sound bites that are coming out. 10.6 billion in rejected claims that Honorable Tuale mentioned are not private sector claims. Can I have Honorable Madenge know that the largest number of rejected claims came from public facilities, especially the National Referral Public Facilities? So are we saying MTRH is corrupt? Are we saying KNH is corrupt? So let us not, I have said there is only one healthcare system. If you go to a private hospital, that bill is paid by the government of Kenya through SHA. If you go to a public hospital, same thing. There's one healthcare system. So they should stop this attack on the private sector. Ayub, let me give you a quick number. Let me give you a quick number, okay. Ayub, Kenya has 226,000 healthcare workers. 226,000. 40% of those healthcare workers are in the private sector. That is about 80,000 Kenyans depend directly on the private sector for their daily life. The private sector contributes 290 billion Kenya shillings to the health sector, okay, which is more than what the public sector contributes. There are 320,000 Kenyans who indirectly depend on private sector employees for their daily life. So today, if the ministry and this government decides that it must attack one part of the health system, it will destroy itself. We want to achieve UHC. You cannot achieve UHC by tying one of your hands at the back. The question I should have posed to Honorable Madenge, I need to pose to Honorable Madenge, yes, as a member of Parliamentary Health Committee, when are they going to audit DHA? Why is DHA running SHA? What is the role of the SHA board? Why are payments being done by DHA? Why are payments being done by third party? Is it right that the CEO of SHA has been reduced to a private assistant to the cabinet secretary. Is it right that the SHA board is a spectator? Before Honorable Duale took files to DCI, what did the audit committee of SHA say about this? These are questions they must look into.
Okay, so let's sample out the other feedback. Brown, I'll come to you. Those are questions from the Health Committee member and the Nyeri Central MP. Okay. So we proceed, and this is from the other viewers who had sent in their feedback. Lekishon Laban says, ghost hospitals funded, billions lost, lives betrayed. The SHA scandal should force Honorable Aden Duale to resign in any normal society. The Ethics and Anti-Corruption Commission tasked with fighting graft does nothing. It has failed Kenyans and deserves disbandment. Enough is enough. Kimoi Gabriel says SHA is a scam. Imagine a merry-go-round chama where out of 10 people, only 2 are contributing, yet at the end of each month, every member of the chama wants to be paid siku ya chama yake. If there is no input of money by government, it cannot work. Sanexon Degure says there are 3 things in this nation that deserve no mercy: hypocrisy, fraud, and tyranny. SHA fraudsters, pretenders that SHA is working well as whoever is protecting fraudsters should be brought down mercilessly. Sheila Sweden says, as a nation, we sometimes embarrass ourselves. How can a system that cost 104 billion shillings fail to detect fraud in SHA? Either the officers appointed by the president are incompetent or they enjoy his blessings to perpetuate such misdeeds. Godi Barasawere says it's now becoming clear that nothing happens by mistake in President Ruto's administration. All acts of impunity, especially that fraud in SHA, appear to be by design and overseen by top officials in government. We must collectively demand change. Kiteke Michael says everything is easier said than done. Politicians wanting something is easy, saying something is easy. The challenge and the reward are in doing. SHA is partially working, but not at the bar of politicians. Critical services are not available.
Correct.
Yes, Brown.
No. Yeah, those are very true and very timely inputs from Kenya, which are actually very true, because we keep saying kwa vitu ground ni different, and when you perpetuate a certain way, people are there to judge you. And I think in 2027, I want to say this authoritatively, that we're going to have a whole debate on health, because without health working in this country, we're not going nowhere. You had asked a very good question about the universal health coverage, and I think we cannot be talking about UHC without financing, and we have a lot of colleagues outside here, and it's going to be a missed opportunity if I stand here and I don't talk about them. Yesterday we had a meeting that was done between the Council of Governors and the Minister of Health. Initially we had back and forth between the COG and the chair of the Minister of Health on how to be able to absorb the universal health coverage stuff. What we need to do, and we need to tell ourselves the truth, is that we cannot achieve UHC without human resources for health. We still are lagging behind. We don't have enough healthcare workers in this country. And I think when President Ruto was campaigning, we were saying that we're going to increase the HRH component. We're going to increase the healthcare workers in this country. We are asking, in all honesty, why don't they confirm? We need to make sure that these colleagues receive. These people have been subjected to torture, mental torture. They have been working with meager salaries. Why don't we agree as the president? The president has an opportunity. You know, we can't be talking about losing billions of shillings, yet we just need around close to 8 billion to confirm these colleagues to permanent pensionable. Yesterday they said that they're actually going to harmonize their salaries, then put them to another up to next year to be able to give them permanent and pensionable. We want to ask Honorable Duale, please, these are your children. These are your brothers and sisters, the UHC colleagues. Please do the honorable thing. What we want to see is that they are given a permanent and pensionable letters, and also they are paid their gratuity, because the contract really highlighted that gratuity. We need these people to be, their morale to be boosted so that they can be able to work. Kenyans are actually suffering because they cannot be able to access care, because even the population rate, the population keeps increasing, yet we cannot be able to transit the terms of these offices officers to permanent and pensionable and pay them gratuity. So we as unions, we actually watching. I think he said he's actually going to meet all the unions on Monday, but we're actually also watching because we cannot be able to sit down and say we can deny, we can allow our colleagues or rather our members to continue suffering with the very, very meager salaries under very tight, very tight working conditions without really SRC. What we are saying is that they need to be confirmed given the SRC terms, given allowances. They need to be given risk allowance. You know, within the health sector, we actually work under very risky situations. They are not actually paid all those allowances. So we need to ensure that the ministry must move with speed, confirm and transit these officers to PNP and pay them their gratuity so that we can be able to have a seamless work.
Yes, Dr. Keller, as well as what happened yesterday between the Council of Governors and the ministry.
Yeah, so first of all, we find ourselves in what we call a moral dilemma, where the private hospitals who are in need for business are being told that healthcare is a right and you have to provide this care. Yeah? And they ask themselves that if you do the right thing, you get punished because nobody's going to pay you and you're going to go at a loss. And on the other side, you are forced to engage in some of this fraud for you to stay afloat. There are certain things, 3 challenges that they undergo that sometimes pushes not just private but even public hospitals to go into fraud. First of all, is the low packages. When you tell somebody that you are going to give 17,000 or 30,000 for a cesarean section, when this cannot even pay for the workers, pay for the equipment, pay for the consumer and the drugs, then you are trying to make this private sector guy subsidize for public healthcare system. That's one. And to cure that, we have a panel that's supposed to handle the packages that should review constantly that, yes, today, the amoxicillin is 50 shillings. Tomorrow, we all know that inflation and all that. Maybe it's 100 shillings. Do we review those things regularly? Or the provider is given a chance to also say how much it costs? I want to give an example around treatment of breast cancer. When you look at the cost of treating breast cancer vis-a-vis SHA, thinking that you're going to only get 600,000 per year, you fall short. 2 is the issue of the payment delay. When you don't give us a predictable, timely pay, that now providers are forced to bribe to get paid. They are supposed to speculate on when the amount is going to come. You don't know when it's going to be flagged as fraudulent. You push people then to cushion themselves by either engaging in unethical behavior or rejecting SHA. Right now, we go to hospital, they say, no, as we don't accept SHA. It frustrates the patient. When you hear that, when you have gone to a mission hospital all your life, then all of a sudden they're rejecting SHA. You get that? So we must look around that. And finally, we must find ways that the government ensures that, we have Ministry of Health, and Leshega is saying so well, there's no public patient for public and patient for private sector.
Patient is a patient.
The wholesome picture of the healthcare system that can ensure that patients are not denied the care based on Article 243 as a right. But in all these, we must ensure that the providers are respected, they are listened to, and they are facilitated, whether in public or private, to chip into that dream that we had when we said that healthcare is supposed to be free. Otherwise, we'll find ourselves in trouble. I keep on saying it again and again, that healthcare is going to shape the next election. Yeah, and I'm glad that in every sitting the president talks about it. And even the media houses, people talk about healthcare every day. Because for a long time, we've looked at the infrastructure, the real estate of development, forgetting that even if you became a professor, you can still die from malaria if the hospital doesn't have the drugs. So let's sit back. It's not too late. That's 1 year. It will shine in a month's time. We can take that 1 year to reflect and bring everybody together to see where can we change, where can we... It's not wrong to change your mind. After all, only a fool does not change their mind. Okay,
it's Dr. Lishenga, the fate of universal healthcare workers seems to be hanging in the balance, and it's a case of the unwanted child by either parties.
Yeah, I mean, one of the obvious things is that the ministry has budgetary shortfalls. When we see, obviously, they will argue that they increased allocation this financial year, but against what we require as a ministry, we are still falling far short below what we... So people keep scrambling all the time. The problem here is literally brokenness. You know, Ministry of Health has been underfunded year after year. And that is why we have constant problems.
How far are we from meeting the Abuja declaration?
So far away.
So
we are talking 15%. This year we're talking 4.6%. And by the way, declining compared to other years as a share of GDP. So we are not funding, and until we get serious. There's something in this country where we have left the healthcare to the common person.
That is true.
Let people fund healthcare themselves. This is very dangerous. Let me say this, Ayub, now that I'm here. The biggest problems we have for us as providers, outstanding liability. As I've said, 43 billion outstanding in SHA, 33 billion outstanding in NHIF, 76 billion in total. The civil servants cannot receive care because that scheme is not being paid. We have a money problem. What we have decided as private healthcare providers, even if our colleagues in public will not fight, we will fight for them. Somebody has to fight for someone. You cannot wait for everyone to come on board for you to say what is right. So, Ayub, I want to even invite you on live. This Friday, we hold a press conference as RUFA, and we declare that if the Cabinet Secretary, Treasury and Health don't pay NHIF debt within the month of September, we as private sector, on behalf of the entire health sector, we will down tools. They must settle. In March, the president made a commitment, in March, that he will pay NHIF arrears. In fact, the 10 million and below was an immediate instruction. Yeah. And this is not...
Was that done?
It was never done. 6 months down the road, the presidential instruction has been ignored. When the faith-based, the bishops went to State House, State House told them, okay, wait, after the budget has been read, in September, we will pay NHIF debt. We are now in September. On 5th of September, private sector will hold a press conference. We will declare that the president promise must be fulfilled, not for the sake of hospitals, but for the sake of Kenyan patients. If hospitals are not resourced, people will keep dying.
It's true. And about the UHC, I forgot. We have to accept that the current devolved healthcare system is not working. We cannot run a healthcare system in a country in 48 different ways. That every governor does what they want, then MOH does whatever they want. The UHC conundrum just happened because somebody decided to hire for counties. Yet, healthcare is devolved and these people work in the county. But because of selfish interest on the payroll and the ghost in it, somebody decided to keep the payroll in MOH. So then, right now, when they have enjoyed their ghosts, now they want to hand back the patients to, and I'm not talking about the current leadership in MOH. They were never there before. This guy just tried to correct a previous mess, yeah? But somebody, after enjoying the sweet part of retaining the payroll, now they want to hand over back to the counties this skunk to carry for perpetuity. And the counties have said, no. Wait. You are the ones who hired these people. You didn't consult us in all these things. You have enjoyed this money from when COVID came. Now, clean this mess. You are going to pay them till their contracts end. And after that, you are going to send them to us, and you have to give us money to be paying them in perpetuity if you put them on PNP. That's a good thing. The problem, and I support that view, but the lie that the countries also come, and I've called them out, that when they refuse to take these people saying that it is MOH's problem, but then they refuse to own that they have also failed to hire people. That's why MOH had to inject more personnel in those hospitals. So it's a give and take. They must all agree they've fallen short, and MOH must also agree on the mistakes that they did.
Thank you, Dr. Dennis Miskela. Gentlemen, your time is all appreciated. It's been 1 hour and 30 minutes. Many thanks for your time. Dr. Brian Lishenga, many thanks for your time.
Thank you.
Brown Ashira.
I really wanted to say one thing,
yes,
a second.
Please.
I wanted to plead with you.
To be fair to you.
Be fair to me. Next time I'll be sitting here. I'll sit here. It appears that I'm overlooked.
Yes.
I'll say this. I want us to reach at a level as a country. We are going to have a debate in terms of health. We need to balance the preventive and the curative arm. For heaven's sake, even the Abuja declaration, even the universal health coverage cannot be realized without the preventive arm. So it is important that while we actually, even look at the Ministry of Health, we have two state departments, that are medical and public health. So let's be able to balance. Even we're talking about the budgeting, let's have commensurate budget for both arms so that we can be able to realize what we need to realize as a country.
Thank you.
And get what we need to get to.
Thank you, Brown, and much appreciated for your company. Always appreciated.
Asante sana.
And Dr. Dennis Miskela, for your time, and appreciated the Deputy Secretary General of the Kenya Medical Practitioners and Dentists Union. Earlier on, we had Dr. James Nyika, lawmaker representing Seme constituency, and the chairperson of the National Assembly's Health Committee, who joined us from Kisumu County and now en route to Homa Bay County. Thanks for your time. Up next is Health and Lifestyle, another health topic with Lillian Moli. And I'll see you tonight on JKL. Till then, good morning.